I promise I will try to keep you awake, showing you also many images and cases to show you how my daily life has changed in these recent years. As Achilleus already said, I was born as a liver interventional oncologist, mainly doing liver ablation, but now the landscape has completely changed, as you will see. And in fact, it is not a novelty that ablation is in the guidelines for the treatment of hepatocellular carcinoma since really many years now, with a prominent role as a curative treatment, as a first-line treatment, especially in low-burden tumor volume. In the guidelines, in the updated BCLC, you will read that when liver transplantation is not an option, ablation is considered equivalent to resection in stage 0 and stage A solitary lesion less or equal to 3 cm. And you will also read that because of less invasiveness and cost, ablation could be given priority. What can we desire most for our interventional oncology technique? But what is really interesting now is that ablation is in the guidelines, the European guidelines from EASL and ILCA for the treatment of intrahepatic cholangiocellular carcinoma. When we have a single lesion less or equal to cm in a patient with cirrhosis, especially, you can consider transarterial procedure or thermal ablation. This is really a new message that is echoed also in the guidelines of the European Society of Medical Oncology. So local ablation is considered among the tools to treat patients with non-resectable intrahepatic cholangiocarcinoma, 3 cm or less in dimension, who have contraindication for surgery. And this is, again, an important achievement. What about colorectal cancer mets in the liver and outside the liver? Again, ablation is here, near to surgery, in the guidelines. Among those treatments, there are many interventional oncology treatments in this table, in this chart, that you can use to treat your patients. Here you can see radiofrequency ablation, but then again, if you go in the document, you will see that ablation as a whole is mentioned. As you probably do, like me, we mostly use microwave ablation now in our daily practice. And remember that surgery is there, but patient relapse after surgery. Take a look at this patient. Surgeons are not doing hepatectomy only, of course, they are often doing liver sparing surgery, and sometimes also they have relapses as we have, and it is then difficult or anyway unnecessary to go again with surgery. This patient relapsed after surgery, you can see here, and we treated with microwave ablation with very good results up to 14 months. And again, you can, I have colleagues, very good surgeons that do advanced liver resection, two-stage resection, ALPS, and so on and so forth. This patient went into the newspaper because she had taken out 50 metastases. What happened at the subsequent follow-up? That she had the 51st metastasis. So the surgeon called and said, can you please ablate this? Because as you can see, the liver remnant was not so much. That's what actually we did, and you can see here the videos of the fusion imaging of the pre-treatment CT and the post-treatment CT, and in the upper video you can see that the volume of ablation covers the small metastases, but if we put margins that are the yellow picture, you can see that there are some places where they were not fully covered. Anyway, the patient is free of disease right for now. And in the document from the ESMO, you will see that there is an important scenario where the role of interventional oncology is really strong, is that of the patient with an oligometastatic disease. These patients has 1 to 5 metastatic lesion, 1 up to 2 metastatic sites, so again, it is not only liver. They should have controlled primary tumor, eventually not resected. All metastasis sites must be safely treatable with local regional therapies. This is what is interesting and should be kept in mind to define the patient with an oligometastatic disease. But then again, an important concept. Your aim in treating this patient can be curative, and of course this is what we aim in most cases, but there are patients when you can also stay with a non-curative treatment, when you are a part of a multimodal therapy approach to control sites of metastasis, to give the patient the option to discontinue his systemic therapy with the goal of local term disease control and improved, finally, overall survival. So this is said by the Oncology Society, so this is very important. And I would like to underline another important scenario, because if in the oligometastatic disease the patient undergoes systemic treatment, we have an initial response and we can treat with local regional therapy, there is another important category of patients, that those with oligoprogressive disease. That means that they are doing their systemic regimen and they have a very limited recurrence in a metastatic lesion. So in these patients, we have a very interesting situation where we have a polymetastatic disease at the beginning of the patient journey. The patient has a good response, but there is one site or really few sites that progress. In those patients, the oncologists are asking more and more to treat with local treatments, not to change the regimens that they are giving to the patient, to wait until the next lines of treatment, and therefore to keep them for further stages and further progression of the disease, making the patient history longer and longer. And this is, for example, a patient that I treated 2 weeks ago. This patient had actually a stage 4 non-small cell lung cancer, metastatic to the bones, metastatic to the brain. She did initially chemotherapy and radiotherapy for the lung. Then she had progressions. She started a TAKE-AI. With TAKE-AI, she had a good response on small metastatic lesions in the lung, apart from the appearance of a lesion in the liver. So she had an oligoprogression in the liver. The oncologist asked us to perform biopsy to assess the molecular setting of this liver lesion and to perform ablation, what we did in the same session with very good results. If you cannot see a very large volume of ablation, speaking about imaging, is because this lesion was very peripheral. The needle, the antenna was positioned in the medial portion of the lesion, and as you can see, there is a retraction of the capsule. So when you are using microwave with high power, you are producing an important retraction of the tissue, like when you put the meat in your microwave oven. It is exactly the same phenomenon. So the concept of oligoprogression has moved outside colorectal mets in other tumors. And interestingly, one tumor where really we thought we never put our hands on is the metastatic breast cancer. In reality, in the ESMO guidelines, there is the concept that in patients with oligometastatic disease, of course, selected under considering their molecular profile and all the oncology parameters, there is a role for local treatments. There is a role for local treatments in metastasis from neuroendocrine tumors, for cutaneous melanoma, for metastasis from thyroid cancer, and everything is already in ESMO guidelines. So this made us put us in front of different patient population we compare with the original HCC patient population. This is a patient with a breast metastasis, very good control after 1 year from the treatment. This was a young lady with a metastasis from ocular melanoma, and we treated patients from many other primaries. This is the patient treated with melanoma, and I would like to show you briefly this case because, in my opinion, can convey interesting messages. This patient had a uveal melanoma in 2013. In November 2019, there was the detection of that focal liver lesion in segment 7. We performed biopsy. We always performed biopsy in this patient. Metastatic melanoma was confirmed. And in December 2019, we performed microwave ablation. The patient started immunotherapy with nivolumab at that time. And this was done well before the publication of the NCCN guidelines that are from January 2023, when you can find that if you do not have a clinical trial, you can consider liver-directed therapy, including ablation, embolization, and so on, in patients with limited distant metastasis from uveal melanoma. We had a very good response on the liver, but some months later, we discovered a metastasis in the muscles, in the left iliopsoas. So again, we performed biopsy. It was confirmed it was metastatic melanoma, and we performed cryoablation of this single muscle metastasis. The patient continued nivolumab, so the concept of oligoprogression was already there. I can show you the images of the cryoablation we performed with 4 cryoprobes. You can see here and here the ice ball with the 4 probes in the muscles. And we had a few months of complete response. So 9 months, 1 year after a microwave ablation, this was fine. 9 months, 4 months after cryo, again, no relapse. What happened then? It happened that in February 2021, we discovered several new lesions in the liver. And because we wanted to understand what we can do, we decided to submit the patient following CT to MR. And as you know better than me, with MR, the number of lesions was definitely higher than what was demonstrated by CT. So again, the patient was discussed at the MTDB, and she was proposed to undergo radioembolization, bilobar radioembolization. She continued nivolumab, but started also with ipilimumab. And these are the 2 therapeutic phases of right radioembolization and left radioembolization. Finally, the patient progressed more, and she stopped all the other therapies. She had radiotherapy for bone metastasis, new drugs, experimental, and then chemotherapy. And she died in January 2023. But as you can see, we discovered the first metastatic lesion in 2019, and the patient died a few years later. That was, however, considered by our oncologic group a great result in such an aggressive disease. So this means that the modern approach in percutaneous ablation means we have to move outside liver. In other organs, we have to play with different ablation modalities, heat-based, cryo, cold-based, and also electric current-based, I mean IRE and RE, and also to go sometimes sequentially or at the same time intraarterially. So this means that we have to work, of course, all together with the oncologists to achieve best results. So moving outside of the liver, what is the role of ablation in lung metastasis? The role of ablation of lung metastasis is interesting because this is a technique that we can repeat differently from others. For example, you cannot do surgery many times or radiotherapy also when there is a new lung lesion popping up somewhere in the lung. And the local control is very good, as demonstrated by this landmark paper by Thierry Debert and his group published in 2015. And this is a case of lung metastasis treated with microwave, you can see here, and the classic imaging appearance after ablation. So there is this ground glass opacity at the end of ablation, and then this progressive shrinkage of the area of the ablation zone throughout the follow-up. In this case, this was a single metastasis of a patient with an HCC, with the classical appearance, hypervascular in the arterial phase, even the lung metastasis. We treated with cryo because it was peripheral. In this case, when the lesions are so small, it is not needed to go exactly in the center. It is very difficult to puncture the nodule. We place our cryoprobes right to the nodule itself, and we obtained very good results. This classical appearance again after cryo with this hypodense area around the GGO area and the no enhancing lesion at 1 month. The bone. Again, the results of ablation in controlling pain, so as a palliative treatment, but also as a technique to control the disease from an oncologic point of view, are there since many years. And this is a nice review where the results in terms of local control are all collected together, and they are all well above 70%, 80% in the majority of the studies. And this is a case of a lady with a bone metastasis that was treated with microwave ablation. We chose this route because this was the ideal route to match the morphology of the lesion with the morphology of the ablation of this kind of antenna, obtaining the results of local control and pain management. While in this case, this patient had a metastasis from follicular thyroid carcinoma, so a really hypervascular one with some vessel in the front. So we decided to embolize the day before and to cryo the day after with 3 cryoprobes you can see here, and this is the control after removing the cryos with the high spol depicting the coverage of the tumor. The kidney. Here the European guidelines, unfortunately, do not help us very much. The NCCN, the American guidelines, are definitely better in putting the role of ablation both in the T1A and T1B, renal cell carcinoma, but the data in the literature are there. This is a nice analysis of the National Cancer Database that demonstrated that the 10-year disease-specific survival of patients treated with cryo was 94% and was comparable to that reported with surgical intervention, and that percutaneous cryo was associated with a low rate of complication as well as a low 10-year risk of hemodialysis. That is another important point in this category of patients. And this is a case of a patient that we treated with cryo together with hydrodissection of the colon here, as you can see. This is the control at the end of the ablation. This is the iodinated saline that was injected to dissect the colon, and this is the control showing the absence of presence of disease. But you can treat renal cell carcinoma even with microwave. This is another case that I took out of our archive, again with hydrodissection and very good results at 6 years. You can see here there is almost the disappearance even of the scar of the treatment. And again, microwave was compared with laparoscopic partial nephrectomy, and the results from an oncological point of view are very similar. And of course, again, when we come to the morbidity and to the costs, the results are in favor of percutaneous ablation approach. Thyroid. So from the abdomen, we move up to the neck, and also to the metastasis from thyroid cancer. These are the European Thyroid Association guidelines joined with FCIRSE, and there is the role of ablation even in this category of patient. You can choose laser, radiofrequency, microwave, and cryo according to the location of the relapse of the disease and the experience you have with this technique. So one scenario that is especially important is locally recurrent thyroid cancer, because the neck that has already been operated is difficult to approach even for the surgeon, for the most experienced surgeon. It is difficult to find tiny areas of volumes of disease relapse. You can use radiofrequency ablation, as you can see here in these 2 cases. These are really tiny relapses in the neck, difficult because of the already the neck was already operated and the burden of disease was very low. Or you can use, like we did in this case, where there was a contact with the trachea, other kind of approaches, not heat-based or ice-based, but in this case we used reversible electroporation with this kind of applicator and we injected bleomycin during the application of the electric pulses. This is a fused CT showing all the positioning of the device, covering, as you can see, we'll see here, sorry, I interrupted the video. Here you can see all the subsequent positioning of the device, covering all the tissue, and the day after, the tissue was already changed his ultrasound appearance. You can see here in comparison how the lesion changed only one day after. Another scenario coming out is the low-risk thyroid papillary microcarcinoma. So patients that should be offered with active surveillance according to guidelines, because they have indolent cancers that may develop or may not. There is an alternative here. It is local ablation. And again, the surgeons are approaching us to offer those patients this kind of treatment. This is a low micro PTC that we treated 4 months ago now. And this is the nodule, 7 centimeters per 5 millimeters. Sorry, it should be less than 1 centimeter. Because the esophagus was here, I initially dissected the esophagus and then placed the needle. This is a microwave needle. This is the results after the treatment. This is the contrast ultrasound before treating the nodules, and this is after treating the nodules. The patient came back 3 months later. First of all, size. 3.7 per 3, so definitely shrank. No contrast enhancement at contrast ultrasound. Locally recurrent prostate cancer. Radiotherapy can be used as a definitive, a radical therapy. Unfortunately, sometimes we have relapses in the gland, and there are also relapses after prostatectomy. Guidelines of the European Association of Urology, together with all the other society, you can find that when in selected patient, you can also apply local regional therapy, even if it would be better to offer them in a setting of a clinical trial. And again, we have some experience in those kind of treatments. This was a patient with the prostate cancer that was treated with radiotherapy. He had the biochemical recurrence. PET-CT demonstrated the focal uptake in the right lobe. We performed the US-guided cryoablation of the right lobe. It is a very small lobe, of course, due to radiotherapy. And this is the result, 24 months, so 2 years after treatment. This was the pre-treatment PET-CT. This is the post-treatment with the photopenic area in the site of the previous recurrence. So the future perspective of ablation are really interesting for the future. We have a role not only as a curative treatment, but also in and oligoprogression, not only in the liver, but also extrahepatic, not only for colorectal cancer mets. So the number of patient candidates to ablation is increasing and will increase more and more. So what do we need to make this come true? We need time. We need time to learn about different cancer diseases because, again, cirrhosis is not the only disease that we have to understand now. There are different chemotherapy regimens, immunotherapy is there, so everything is moving a lot. We have to learn about technical specificities in extrahepatic location. Prostate and neck are not the same as liver, of course. We have to join multidisciplinary tumor board and answer the phone and the text. We were speaking with Miltos this morning. We have in our mobile, in our email, a lot of cases that we receive, and we have to answer to these emails and texting. We have to meet and speak to the patient and become more visible. So I would like to thank you very much, FCIRSE, and welcome. And of course, we are waiting for you at ECIO in Palma.
Thank you so much. Thank you, Laura, for this majestic journey from the liver and the established treatment of a technology that caused revolution in the treatment of the liver towards the management of oncologic patients. And as I was looking through your slides, I was wondering, it's something that comes to my mind. What would have been the world of oncology without ablation? We are very lucky to have experienced this kind of transition in the management of oncologic patients. We have prolonged, I wouldn't say cured, but definitely prolonged the life of so many patients with this technology. That's truly fascinating.
Yes, I agree. And finally, I think that the fact that we did this work on patients, not only in the studies, came very, very out to our oncologists that are near to us in every single hospital. So this is very important.
We all noticed, and we discussed also that yesterday from this Congress, that there is our very rapidly progressing specialty of interventional oncology has reached a level of maturity. Now we see all these guidelines of oncologic societies worldwide embracing ablation for small volume tumors, and this is a reality. We still have the pressure from oncologists on data, say there's no data, but my idea of a rapidly changing world where embracing new technology is the new reality, not only in medicine, everywhere. I think we have to be pragmatic here. And if a patient gets benefit from what we can offer, if we prolong the lifespan, if we increase quality of life, if this can be offered without them staying in the hospital for a month or two, this is the new thing. That's it. Of course, data will come, but expert panels, guidelines is the way forward, in my view. I don't know what you think.
Fully agree, Miltos, definitely. So nothing to add to this statement. Thank you very much.
Well, we're truly delighted to have you, Laura, today. We will definitely be in the Congress in Mallorca this year, which you'll be chairing, and I let Professor Hadjioannou for his comments.
Excellent lecture, thank you very much. In the obviously era of ablation that is coming in the oncology treatment, I want to change from the opposite side the question. With all the new technologies, the new guidance technique, the PET during the procedure to see the AO zone, what's, up to your opinion, will be the role of surgery?
Well, I think that surgeons and us are very similar. So we have the same perspective. We want to cure the tumor and the safety margin. So we have to work together because there are some patients that we cannot treat and they can treat. In the majority of patients, we are really complementary, especially in the liver. Let's think to liver lesions. There are places where we can reach the tumor in 20 seconds, and they will need to spare a lot of parenchyma, liver parenchyma. So we are, especially for some locations, we are really complementary. And we can go in the operating room with them if it is needed to do everything at the same time. But sometimes we can plan and do first ablation and then surgery and the opposite. Then there are cases, and this is important, when we have relapse after surgery, because surgery is not perfect, or cancer is very smart and comes back. So in the cases that I've shown you, we had amazing surgery before, but then it was too hard to go again with surgery. And this applies to the liver, to the neck, to the prostate. When there is a relapse in the site of prostatectomy, they often ask us to go there with ablation or radiotherapy. There is a relapse after radiotherapy, not only in the prostate, but also in the lung, in primary lung cancer. So that is considered a place for radiotherapy to go. So I saw so many scenarios where there is not a competition, but rather an integration with surgery and with the radiotherapy, because we do not have to forget that that radiotherapists are our brothers, I would say. They work with imaging as we do in a very similar way, but too many times we have been in competition, while again, there is the room to go together to work on the same patient sequentially or combining therapy. That is why at the next ECIO, we will have a session, ECIO meets ESTRO, exactly for this reason, to try to start to work together, because work together is the strength that we have to go for.
Any questions? Thank you very much, Professor Crocetti. We'll
welcome.
discuss that again in Mallorca, of course.
Yes.
And
Waiting for
we're very
you.
glad to have you with us.
Thank you
in
very
Athens.
much. Very honored.
Thank you.